good morning again, everybody, and welcome to another edition of You and Me and Multiple Sclerosis. My name is Pam, and I've been living with multiple sclerosis for nearly 37 years. And in that time, I think I've learned and discovered some interesting things that I'd like to share with you, and hopefully be an encouragement. Well, last video, I had Trigeminal Neuralgia Part 1, remember? That was before my big dental appointment where I was going to have 2 molars taken out, and I was concerned about what was going to happen with my trigeminal neuralgia, which we talked about. Well, here I am 6 days later. It's not been quite a week, but I have had the surgery. The teeth are gone. The gums are healing. I'm sitting here with my cup of tea. Here, I'll show you my cup of tea. Sitting here with my cup of tea, and I am feeling pretty good. So far, no trigeminal neuralgia. In fact, not much pain at all. I think I mentioned in the last video that my oral surgeon put me under entirely. I was under anesthesia, but the procedure apparently only took like 30-40 minutes for 2 teeth. And they were indeed fractured. He had to take them out in chunks and all that. Sorry, probably too much information for some of you. But you know, that is the exact kind of thing that could trigger your trigeminal neuralgia. Because as I showed you in the diagram last time, the mandibular branch of the trigeminal nerve runs right underneath those teeth. And certainly the roots going down into the jawbone and everything. It could have been pretty bad. But he claimed to understand, what TGN is, and he put the needle right where he felt it needed to be, but not trigger anything horrible. And so far, so good. Now, I will say that I have not had an attack for quite some time now. It's probably been a couple of years, and I don't know whether, I don't know what the future holds for me with trigeminal neuralgia, but I do think that once you have it, you always have it. It doesn't go away. It's kind of like MS. You're just sort of stuck with it. But I did mention in my last video that it is not a common disease, and it's not even necessarily a symptom of MS. It can go along with MS. In fact, one site that I looked at said a form of trigeminal neuralgia was a symptom of MS, but they didn't really go into great detail about that. However, they did say that just like MS, way more women than men get trigeminal neuralgia. And then also they said that it affects about 150,000 people, and I think they meant in the United States. So I don't know about worldwide. But 150,000, and compare that to the population of the United States, we're not talking about a disease that affects such a large number of people that scientists are frantically searching for a cure or even a successful treatment. Well, I did get curious about that, and I thought for the second part of the video, I could talk about treatment options for trigeminal neuralgia as it stands right now. And I will say right off the bat that since about, 2007 or 8, whenever it was the last time I really looked into trigeminal neuralgia treatments, there really haven't been any radical new treatments, but I will review what there is so that you know what your options are, and that will be helpful. I should also mention that I just routinely take gabapentin for other MS symptoms, and it is one of the things they prescribe for trigeminal neuralgia, so for all I know, that could be helping me, kind of running in the background, so that, I don't get it or I don't feel it or whatever. But the dose is kind of low, so I'm not really thinking that's it. Anyway, let's go over some treatments that I found on the internet that we can talk about. And I only looked at reputable sites because there's all kinds of craziness out there. I found ads for things like topical cream you could put on or supplements you could take. And, I just don't have a lot of faith in that. I think people are desperate to try anything. If you've had good luck with anything like that, I'd love to hear it. But I don't know that something that severe is going to be curable or treatable with something you can buy over the counter. Sorry, but I just don't think so. Okay, so when we look at trigeminal neuralgia treatment options, I'm grouping them into basically two kinds. I've looked at several websites, and this is not how they organize them. But when you think of the nerve, right, you've got the actual physical nerve itself, and you've got the electrical impulses that travel through the nerve. So I divided the treatment options into the kind that deal with the electrical impulses, and then the kind that deal with the actual mechanical functioning of the physical nerve. So why don't we just go ahead, we'll start looking at some of those, and I'm going to go pretty broad brush over this because there's a lot more to it. And if you're interested, you can follow up on anything. I got my information primarily from two websites that I will link below. One is the American Association of Neurological Surgeons, and the other is the Mayo Clinic. Okay, so under electrical treatments, we find our anticonvulsant drugs that many of us are familiar with. Carbamazepine is the big one. Its brand name is Tegretol. And then also gabapentin, which is called Neurontin. That's the brand name that it's sold under. Those actually are anti-epileptic drugs, right? They are used to treat epilepsy and migraine or the pain associated with those. They don't cure, but they cover the pain. So in other words, they're masking the electrical impulses in some way. We're not feeling the result. And the same with the antispasmodic agents, looking at the nerve as having essentially a spasm that's going on, right? You could say that this is actually probably belongs under mechanical, and I probably should have thought of that, but I think when you see how they use it, they often use these in combination with carbamazepine. Electro and mechanical, you can't really make a firm distinction between the two. An antispasmodic is a good example of where you see it kind of crossing over one side or the other. Okay, now the next several, they're all called percutaneous something or other. And percutaneous means through the skin. So per means through, and cutaneous refers to the skin. So percutaneous radiofrequency rhizotomy, as it says here, it treats trigeminal neuralgia through the use of electrocoagulation, which is a big long fancy word for heat. So they use heat to relieve nerve pain by destroying the part of the nerve that causes pain and suppressing the pain signal to the brain. So again, you see how that's kind of electrical and it's kind of mechanical at the same time. Neuromodulation involves placing electrodes in the soft tissue near the nerves, under the skull, the covering of the brain, and sometimes deeper into the brain to deliver electrical stimulation to the part of the brain that is responsible for sensation of the face. So that's a quote from the website, from the AANS website. And that sounds like a procedure indeed, but you're looking at something to block or change the electrical impulses that are causing trigeminal neuralgia. So mechanical treatments for trigeminal neuralgia involve some of the ones I've listed here. And this first one, microvascular decompression. Big fancy term, but basically vascular has to do with the blood vessels of the body. And micro means small. Decompression has to do with decompression, right? I think you kind of know what that is. So you've got this exposure of the nerve root, and it sounds pretty intense, right? You identify the blood vessel that may be compressing. So in other words, a nerve is being pressed on by a blood vessel. So if we physically move the blood vessel away from the nerve, or at least the point of the nerve where it's being compressed, we can relieve the pain. So that's a very common one. That was very common even when I first got trigeminal neuralgia and I was looking at the different options that were available to me. The next one is another percutaneous, but this time we use a balloon. It uses a needle. It goes through your cheek into your trigeminal nerve, and there's a balloon placed in through a catheter. The balloon is inflated to where the fibers produce pain, and then the balloon compresses the nerve and injures the pain-causing fibers and then is removed. So in other words, we're causing a mechanical injury to the nerve itself in order to stop the pain. And then another percutaneous, this time we're doing glycerol rhizotomy, and this one involves injecting glycerol through a needle into the area where the nerve divides into the three main branches. And you remember from my first episode of this saga, I showed you the sketch of the three branches of the trigeminal nerve. So that's where they would put this glycerol. The goal is to damage the nerve selectively in order to interfere with the transmission of the pain signals to the brain. So there you go, another mechanical solution to the pain. And then we have a couple others here that I wanted to show you. Stereotactic radiosurgery. So there's a bunch of different techniques that are pretty much delivering the same kind of relief, or at least that's the hope. It involves ionizing radiation to a very small target of the trigeminal nerve root, so that, in other words, it's going to cause damage, what they call a lesion, a formation of a lesion in the nerve, so that it will interrupt the transmission of pain signals to the brain. But you might guess that something like this, and actually a number of the mechanical ones, have the same side effect problem, and you can decide how desperate you are that you may not even care. But if you damage the transmission, if you limit the transmission of signals, you're not just limiting the pain signals, you're limiting all signals. So you may end up with permanent numbness in your lower jaw or wherever else you're having this trigeminal neuralgia pain, and you may choose that that's worth it to you. And on the other hand, you may say, well, I don't know, I got to think about that one, because permanent seems pretty dire. Okay, so finally I wanted to talk a little bit about this last one, Botox injections. There's studies that are ongoing that toxin may reduce pain from trigeminal neuralgia once you're no longer being helped by medication, but unfortunately they haven't really done enough studies to know for sure whether this is really going to work for enough people that it would be worth making it available. But that is a new one, and you might ask your doctor about that. Okay, I also wanted to talk about clinicaltrials.gov, because if you check in there for trigeminal neuralgia, you may find that they have a study ongoing that you would like to participate in. Here's one right now that is active, although they are not actively recruiting anymore. It's called electroacupuncture therapy for change of pain in classical trigeminal neuralgia, and it's being done in a medical university in China. They have published the preliminary plan for the study, but we do not yet know what the results will be of the study, so we don't know whether that's going to end up being viable or not. But I wanted to mention something about clinical trials. I think that they can be extremely useful. In fact, medicine advances largely because people volunteer to be subjects in these trials. There might be, in some cases, a small remuneration that you would get. But here's the thing. Okay, now this is my personal feeling, right? It's fine to help science, but if you're in raging, horrible pain, You kind of just want something that's going to work. You don't want to take the chance that you're in the placebo group and you're not getting anything at all. So you're going to have to just live with the pain, because I have a feeling they're not going to want you taking something like gabapentin or carbamazepine or something else to deal with it, because that will skew the results. Well, do you really want to be in raging pain just for the sake of science? Well, you know what? You may be so altruistic that you're willing to do that, but I will confess to you right now that I don't think I'm all that altruistic. And another thing I have to chuckle at, one of the sites that I looked at, I don't think it's one of the two that I mentioned here, but they talked about, well, there are treatment options, but the side effects can be unpleasant. Okay, I had to laugh at that. Unpleasant as opposed to excruciating. Okay, I guess I would rather deal with an unpleasant side effect than the excruciating pain of trigeminal neuralgia. Anyway, that's the treatments as they stand now, so that if you do have trigeminal neuralgia, talk to your doctor or other medical professional that you see and see what they recommend that you try. And it may be a trial and error thing. But I do believe that we need to avail ourselves of whatever treatments there are, because it's a horrible side effect of neurological chaos, which is kind of what's going on with MS. It's that our body's just in some form of chaos and revolt. And trigeminal neuralgia is probably the most severe form of that. Well, that's all I have for you today. I just want to let you know I'm home, safe and sound, and so far so good. If things change on that score, I will let you know, because as I said, trigeminal neuralgia, it can strike anytime, and it might just be planning its next move for all I know. It might be lulling me into a false sense of security for all I know. But for right now, things are good. And I'm always happy when things are good, right? You can agree with that. When you have a good day, you can rejoice. So let's do that. And I will see you again in my next video.